overview, you see here it's a vertex presentation. And the heart is here. We have good scanning conditions despite an anterior placenta. Arrow. So, and I was asked to scan the heart on 2D and color. And then this is the general OB application. We'll move now to the heart preset. What I do in general in the heart, especially when we are scanning for with color, I'll check the frame rate, and they are here 74, which is actually very fine, especially that when you'll add color Doppler, it will go down. This is why, let's say, the major approach you should think about is always to find a way to increase the frame rate on 2D before adding color. I do this by narrowing the aperture on one hand, and you see here we moved up now to 93, and then by changing the depth. So, and we are now just starting by 125, and then let's magnify the whole picture. No. So, and now I think you have a good view. Give me an arrow, please. This is the arrow. What we see here from the lateral approach, and you see we have a shadowing from the rib. I try always to get, as you see on my hand, from, let's say, the part where there are no ribs. We see the right ventricle, the left ventricle. We start by the upper abdomen, recognizing the stomach, descending aorta, inferior vena cava with the abdominal hepatic vessels, the right ventricle just behind the sternum, the left ventricle, the septum being nicely seen, the foramen ovale with the flap of the foramen ovale. You see here the left ventricle, the papillary muscle going to the free wall, on the right side, the moderator band here with the papillary muscle going to the septum, to the apex. And then from this view, we tilt slightly the transducer to see the ascending aorta. And you see this is the right ventricle, and in a more cephalad plane, by moving a little bit up, we recognize how the pulmonary artery is going into is arising from the right ventricle. And by tilting the transducer, you see the bifurcation of the pulmonary artery into the right and the left branch. And we move back to the four-chamber view, and we move slightly parallel to the upper thorax. And then you see the so-called three-vessel trachea view with, on the right, the superior vena cava, in the middle, the aortic arc, and on the left, the pulmonary artery with the ductus arteriosus. This here is the isthmus of the aorta. In the afternoon, in the borderline session, I will be discussing the position of the aortic arc. It is the position in comparison to the trachea, which is this echogenic dot seen here, and this is a normal condition. Because we have a high resolution here, you can see even this black part, which is the azygous vein, which is actually here near it's very tiny here, it's near the descending aorta and going up and entering the superior vena cava. From this, in this plane, if you go for even higher resolution, you see the two lung lobes, and just in front of the three vessels here, this is the thymus, well seen. And even in higher plane, you recognize a kind of vessel here, an oblique vessel, and this is the vein called the innominate vein or the brachiocephalic vein. So we published with Alfred and with Elena this last year a paper on this condition, then you can refer it in the White Journal. So this is on 2D what you can see. Of course, if you are very good, you can start to recognize where are the pulmonary veins here and there, and but I will prefer to do this on color Doppler. Now this position is good for starting with color Doppler on one hand, but as you see here, if you are scanning within a horizontal way, you don't have a pretty nice color because it's horizontal perpendicular insulation to the flow. This is why in these conditions I will first try to make it slower, smaller. Okay, so what I do here, depending on what I'm going to scan, if I want to visualize the perfusion of the AV valves, I try either to get apical, which is not possible here, or I go backward and try to get more a basal approach. Now the baby wakes up. So, and then from this view, I will add the color to see the filling of the chambers and increase the PRF. You see the trick. Now I see clearly the filling of the chambers, and I can say, at least in this plane, there are no signs of large VSTs. There is no tricuspid or mitral regurg. There is a good filling of the chambers, and I've seen, let's say this is the answer I want for the four-chamber view. Now remove the color, and then go to the next plane, which is the ascending aorta. The flow in the ascending aorta will go upward in this direction. I'm visualizing this. You see, it's not the ideal scanning conditions, but enough to say that I have here, do less gain. I have here a nice ascending aorta, well seen, and then increase some PRF. So remove the color, and then move the transducer to see the apical approach to the pulmonary artery, and then I will go this way. Now, in many cases, you need more sensitive color, and this is why we use the dynamic flow here. And what you see here is the perfusion from the right ventricle into the pulmonary artery, into the ductus arteriosus in the three-vessel trachea view. And this is what I was saying a couple of days ago. This plane is also ideal in early gestation, where you can demonstrate the integrity of the three vessels in this plane. Now, we occasionally want to smaller the picture. Yeah. So if we want to see some more tiny vessels as the lung veins and the subclavian, what I do first is to try to see them on 2D, which is roughly for the right inferior vein in this region. I will add the dynamic flow. And then as you see here on the left side, I hope you can see it, we are at 62 centimeter per second. I will lower the PRF and see what happens now, how nice the veins are coming. You see here both inferior and superior right veins. And this is a very good plane to visualize these veins. I will stop here, and you can see on CineLoop the two on the right. And then I can do the same for the left one. For the left one, they are in general perpendicular to the interatrial septum. That means they will run into this part, and I will try to see it this way. Oops. Maybe stop moving now. Okay, and add the color here. If you know where to look for, you can do the color very rapidly, because you are. The disadvantage of this position is that you need several planes to do every single answer to a question, but in some conditions, if it's apical, you can do it straightforward within 1 or 2 sweeps. Now, if I have this preset, I will move the same preset of the color to the upper thorax. That means in this plane, and then I will expect, if there is an aberrant subclavian, to see it behind the trachea, and if it's normal subclavian artery to the right, I will see it just in this region in the upper thorax toward the clavicula, which is here. So I'll show you how it is done. 3-vessel view, add the color. And we see if behind the heart, behind the trachea, there is a vessel. You see here only the azygous vein entering the superior vena cava. And we move upward, and you see a kind of S-shaped vessel. Do you see it? Alfred, are you still there?
Yes,
okay.
We are here.
Okay.
We are mesmerized.
So, and this is the subclavian artery, and the same here is the brachiocephalic vein or innominate vein. And just as you see here, the 2 mammalian arteries around the thymus, what Dario described nicely as the thigh box. That means we have seen everything you wanted to see at the level of the heart, and the only thing I couldn't show you are the coronary arteries, but this would be shown next year at the World Congress.
Rabbi, could you go into the cardiac, the aortic arch and the sagittal, parasagittal?
Okay. The sagittal view of the aortic arch.
Yeah.
Now, this is a tricky question, because I need a plane exactly here along. I will try to rotate along the arc and then demonstrate. You see here, this is the ascending aorta. Under the arc, there is the right pulmonary artery branch. You see 1, 2, and 3 vessels. This is the arc.
Maybe you can point where are the common areas of coarctation.
This is the region of the isthmus, exactly here, after the 3 vessels rise from the aorta. This is where we'll expect to see coarctation. In general, in true coarctation, you may have even that the last vessel, which is the left subclavian, will be arising from the descending aorta, and then it would be in this region. That means the region after the 3 vessels has arisen from the aortic arc. So, and this is the esophagus, very well seen behind the heart. The area behind the heart include mainly the descending aorta, very tiny azygos, and the lung veins.
Any questions from the audience? Or anything you would like to see?
Here, this is the esophagus again. Inferior vena cava, ductus venosus, stomach. So, okay,
And
some Doppler on the aortic valve.
Maybe show how to assess the septum, because the baby is in a good position for that, for VSTs, for muscular VSTs.
You hear this is the ascending aorta. Yeah, for muscular VSTs, you will. Okay. I will add color like this and then increase the PRF and check for crossing. It's not so nice now. Let's fix it, okay. And check in the middle region here, by lowering the velocities, if there is any color crossing the midline. And for the perimembranous, I will opt for this plane to see that there is no VSTs here. What I couldn't show in this plane when I was scanning from the lateral approach is let's say the position of the valves to each other. And this what we can do is we can go this way here. Oops, sorry. Oops. Wait. And we'll wait to have closing and opening of the valves. And you see that the right valve is lower attaching than the left one. Okay. So it's fine.
Great. So last call for any questions from the audience or comments. Yes, we have one question. If you come to the microphone. The middle maybe is closer.
Thank you, Alfred. Rabbi, would you please, any value if we measure the flow velocity between the ductal and aortic? Any clinical value between this ductal flow and this aortic flow for clinical point of view? Thank you.
So
is the question, is there any clinical value for routine Doppler of valves?
Yeah, maybe let's say we want to predict some fetal heart disease like coarctatio or maybe PDA in the future of the baby or something like we can this ductal flow velocity
Yeah.
between?
Well, there is a debate on whether we should do routinely pulse Doppler on every valve. And we had this discussion when we were writing the consensus of fetal echo published in the White Journal. Let's say, in my opinion, if you are working like on this fetus and you have an homogeneous flow, show you again, laminar flow on color Doppler. With HD, let's say with dynamic flow, it could be problematic because you may not see clearly some turbulences, but let's go for color Doppler. If you have this kind of flow, I don't see where there is a space for pulse Doppler to see any abnormality. So unless you have a preset like, this one, I go down with the peak velocities, and if you store such a picture on your documentation and the child has an aortic stenosis, you may come in trouble. This is why if you see all the time such a picture, then you should go and Doppler and sample it. And the other exception in my unit or my work is then once you have a typical family history of one condition. Let's say one previous case with hypoplastic left heart aortic stenosis, bicuspid valve, or family history of left ventricular outflow tract obstruction, then I sampled the mitral and aortic valve to document that I was targeting this question. This is my opinion. The other question where it can make sense is to sample the pulmonary veins, because especially in left obstructive diseases and in abnormal lung vein connection, it can be helpful. But at this stage, you see the normal flow. At this stage, if you are able to see the whole details and to sample them, you are already, let's say, performing very high-level fetal echocardiography. In other words, rather no. We do it, for example, routine for ductus arteriosus when we were having indomethacin therapy on the ward and these things. But in general, this is a target question, not on a routine scale.
Ravi, can I ask you one question? During routine screening, do you look at aortic and ductal arches in long axis views?
I don't know.
Yeah. No?
Alfred, can you repeat the question?
Yeah, the question was, in your routine scanning, do you always look at the ductal and aortic arch in the longitudinal view and the parasagittal views?
No. Because look at now this view here, there is no way to get easily the ductal arc. And I challenge you to tell me what is the information I can get more to make it worth looking for this. The coarctation question, for me, if you have a normal-sized chamber like here and normal three-vessel view on a routine patient is enough. If you have a left superior vena cava where it could be possible that there is there, or a family history or other things, then yes. If you have something like thickened nuchal and you think it could be Turner syndrome, then yes. But for me, is this enough to have this documentation of this plane and that plane?
Yeah.
But let's say in this condition, I showed you how I take it abdominal, but let's say from apical, but I will try to turn the baby because the other plane to get aortic arc is from here. Make the picture smaller. I show you, the baby is now turning this way. But I try to turn the baby to get the other view. Will you help me? And then.
Not anymore.
So.
I agree with you. I don't think the long axis views are required for routine screening. I think most of the information you can just get from three-vessel tracheal view. So thank you.
So wait, I'll show
Do we
you
have
how.
any other question from the floor? No? I think we should start with our first speaker.
Thank you.